social demographic backgrounds, people who are diplomats, then you get someone from Nakaseke, rural Nakaseke, and you get the other issue, because we thought it was something, we thought it was an opportunity, and train them so that they can offer basic psychosocial support to those that need, because through the home-based care strategy, it will be difficult for us to actually provide support at the community or village level. And then we're also completing a comprehensive image COVID-19 and other crises yes to come. So that the challenges that we've faced.
Comments are coming through. Later, when we open up for reflection, I will be reading a few of the comments and questions coming in from online. And thanks so much once again, Dr. Kalani, for that elaborate presentation. He mentioned of fear being one of the issues, and reminded me of one of the frontline workers who said during the time when everybody was at home, driving in Kampala city was scary, because Kampala, people are used to that noise and the buzz and everything, but this time around it was very quiet, and indeed it was scary to the frontline workers doing their work at that time. Ladies and gentlemen, those following us online and those physically here, you will forgive us. My terms of reference were supposed to, I assumed office 10 minutes to 11, so you'll allow me extend by a few more minutes to give our last panelist opportunity to also share with us. And our last panelist.
All the thoughts may lead to someone taking substances and previously attempted suicide, and then also having a family history of suicide, and then people who tend to communicate about suicide intent. Here, I mean, okay, I can give an example. Come and ask you politely, and it's like, do you think if I took this, what will happen? Do you think someone can die if they take this? So that one can give you a clue of his thoughts. And then childhood adversities, then isolation, which may be due to separation, divorce, and then unemployment or major financial problems, and severe negative life. All these are risk factors in the general population. But then when it comes to human care, so that they are able to screen for suicide ideas, for those ones who have suicide thoughts, they can be able to be screened and referred to maybe a counselor or someone who is available to help. And then, however, the health professionals cannot help other people in the communities. So the support systems in our communities, the churches, the social groups should also be empowered so that they can support each other. And an example I can give is, I was doing some work with MTI, and we had difficulty with the language. We really felt that we could not help these people. So what we did was to look for people who had similar experiences, and then we trained them. They would understand the language, and then they formed support groups. And it really helped a lot, and so many people were coming. So they would train, one group would train another group, and at the end of it all, it was a chain of groups, psychosocial support group, and it was really helpful. So I think those of you who are working in humanitarian settings, you can also focus on lived experience to help their fellow people, because they understand their situation more than you. Yeah, I can conclude by saying mental well-being is just as important as your physical well-being. And then regardless of the race, ethnicity, immigration status. Refugees are not alone. When they come, they need to be supported. And then suicide prevention in the